Welcome to Vein and Lymphatic University. My name is Lowell Kabnick, and I am very happy today to have a discussion on the following, and that would be comparisons between rotational and non-rotational MOCA, when to use, efficacy and safety outcomes. Javier Serralde, welcome. He's our featured speaker. Imre Bihari and Tomasz Urbanek will be our discussants. So Javier, if you would share
Hello,
your...
hello to everyone. It's a truly pleasure to me to join with all of you in this moment because this is a very interesting topic, and I'm so happy to meet with very international people and some friends from around the world. Thank you. So, well, in this moment, I want to talk to you about this topic, the difference between rotational and non-rotational MOCA of the great saphenous vein. So this topic, I decided to speak 1 year ago because it was very important to me to identify what was with the patients after the procedures, because many years ago, we decided to start to treat patients with rotational MOCA. So along the time, for approximately 7 years, we can identify that these kind of patients, they refer to return the pain and some symptoms. And also with the various veins, we can identify the new veins, we can identify the change of the skin, and the patient asks us, what happened? Because many years ago, I received the procedure. So for this reason, we can review this technique with another colleagues, and we can identify the recanalization in approximately 30% of the patients after this technique. So on the other hand, we decide to use another kind of device. For example, we use the non-rotational catheter, and with this technique, we can appreciate the difference because after 4 years, we can identify the occlusion rate approximately in 90% of the patients. With the both techniques, our main objective was to the extrusion of the venous endothelium and to get the fibrosis. And in this kind of devices, the difference is with Clarivane, we use the motor, and with Flebogrif, we use the blades. And in both cases, we use the Polidocanol to 3% in our patients. The rotational, all of you know what was the main objective, the advantage. And in this case, we damage the endothelium with the rotator cable to 3,500 revolutions per minute, together with the Polidocanol. Yes, this is very common, very easy. And with the Flebogrif or non-rotational device, the mechanical endothelial damage is using the self-retracting blades. And after that, after the first 10 millimeters, we use the infusion of the Polidocanol. It's very easy. The first part, only the first 10 millimeters is only mechanical. After that, we can continue with the mechanochemical ablation with the Polidocanol with foam to 3%. Until to sheet and close the device. After that, we can review another kind of studies because in this trial, we can identify the follow to 1 year, the MOCA versus radiofrequency, and they can identify the similar results. This is a study in Mexico that I say that after 3 years with Clarivane, we can identify the recanalization in 30% of the patients. In 2025, we decided to say in this study, we need to modify because the occlusion rate was in approximately 70%. Another publication, for example, in 2023, after 5 years, they reported the occlusion rate in approximately 79%. We can view another study with 200 patients, and then can identify the occlusion rate in 90% with the patients. we can identify some complications. But after 2 years in our study, we can identify in 320 grid saphenous veins after 3 years the occlusion rate in 90% with our patients. So it's possible to get some complications. For instance, we identified in 3.75% the thrombosis in the saphenous femoral junction. These patients, we decided to treat with anticoagulation for 4 weeks, and fortunately, we can get the absolute recovery in this time. We can get the minor events, very common, at least in 20% of the patient, like tuberculosis, ecchymosis, phlebitis, and hyperpigmentation. So, as a conclusion, I want to say to you that the non-rotational catheter of MOCA is better than rotational catheter because the non-rotational technique, we can get the less recanalization at long term, approximately, we are cursing the 5 year. So the non-tumescent anothermic technique with non-rotational, it's very safe, it's very comfortable to our patient. The venous total occlusion, it's same to another thermal techniques, like to 90% to the first 3 years. Fortunately, we don't have any neurological damage, not skin lesion, and I want to say we can get the similar results due to the radiofrequency, and also the venous thrombosis. It's possible in approximately 3.75% of our patients. Anyway, this is all of to me, and thank you so much.
Thank you, Javier. That was brilliant. I want to introduce Imre Bihari, who was the PI of an Invira study. And I just wanted to mention that Invira, which is a mechanical-chemical non-rotational device that Imre will be talking about, has been approved in the United States. It's gotten an FDA clearance as well as a CE mark. So Imre, the floor is yours.
Yeah, thank you very much. So first of all, I'd like to congratulate to the results of Javier. It is really excellent, but I intend to speak about a third possible solution, an instrument which we have some experience, not too much, but we have good experience. This is a special wire made of nitinol. This means that this can change its shape as we push out from the sheath, and this will have a spiral, a helical shape, and on the surface of that, there is a rough surface which can ablate the inner surface of the vein. So this is rather similar to Clarivein in that regard, that this makes some damage of the intimal layer, but it is different because this is not a rotational instrument. So we introduce this instrument into the vein, and there it gets the helical shape, and then we pull out this round instrument and ablate the intimal surface. And after that, we inject some foam, 2% Polidocanol foam, and this makes an occlusion of the vein. And we performed a little study with 10 patients, and we found that even after 1 year, in 90%, in 9 cases, we saw the closure of the GSV. So this was not really a long follow-up, but it was a good result follow-up. There were not any complications, which I think it is really important, no side effects. So every patient was very contented with the result, and it could be performed with a minimal pain. We punctured only the site of the introduction place, and we gave a very little amount of local anesthetic. So I think this is a third possible solution which will be used in the future, I think, and it is rather simple. It is not necessary to to make a long study to use this. It is really a very simple and useful instrument. I will have some questions to the presenter, but maybe in a next round, or I don't know. How do you think?
So, Imre, if you have a question to Javier, you can present it now, but I do have something that I would like to add. You used 2% Polidocanol, and if I understand correctly, in Hungary, that's all you have is 2%. You don't have 1%. Is that correct?
Yeah, 0.5%, 1%, and 2%. These are available in Hungary, yes.
They are now. Okay. So why did you use 2%?
I think it is really effective, more effective than 1% or more effective than 0.5%. So it seems it is necessary, a 2% Polidocanol foam for a good result. So I am happy with that. I don't think we would change that.
It's interesting that you say that because in the US, we are going to roll out a post-market study. For those people, I am a consultant with Invira as well. And so there'll be a post-market study. And as you know, in the United States, we only have 1% Polidocanol. So the question is whether we use 1% Polidocanol or switch to Sotradecol, but we're going to do 1% foam. And as you know, Varithena, which is a Boston product, is 1% foam. So typically we get good results. So it'd be interesting to see if we do a comparison study between 1% and what you found. That being said, I'm going to ask you if you have a particular question that you want to share with Javier.
Yeah, I'd like to ask him that was the selection criteria? Which patient got the MOCA and which patient were to thermal ablation? What was your point to select patients?
You're on mute, Javier.
Okay, thank you so much. I can hear you, or you can hear me. Okay, congratulations. Very interesting study, Dr. Bihari. So in our case, we prefer to apply the MOCA when we can identify the diameter of the great saphenous vein between 5 to 10 millimeters. So in the last 2 years, we prefer to use in size to 5 to 8 millimeters, because in this kind of patient, we can identify the best results.
Thank you very much. Thank you. And which thermal ablation did you use?
For example, we can identify more size. Obviously, I can use, for example, the laser radiofrequency more than 6 millimeters. But I have some patients with 14, 16 millimeters with the great saphenous vein and some dilatation. And in these patients, I prefer to use the laser, for example, because with the tumescent, I can reduce the diameter of the vein and with very nice results.
Thank you very much. I'm going to switch to Tomasz, who is also involved in a study of Flebogrif. Tomasz, the floor is yours.
Hi, thank you very much for invitation. We have 2 CE-mark devices in Europe. We know both of them. Personally, my preference is to use the Flebogrif, which I find first easier and probably one of the fastest way of closing saphenous vein, if I am choosing MOCA, of course. And there will be also one question concerning this to Javier. Among the advantages which I see regarding the non-rotational is, first, we give foam, not liquid. We know that foam is much potent. Second, the risk of the stacking to the wall, it's not as high, and you always can close the hooks if the patients start to report the pain, go 1 centimeter below and reopen, so you can control this. And then also the spasm, and this is probably for both MOCA, it's a huge one. That's why you can treat really long segment of the vein using the foam. In the study which we perform on 200 patients, we treat 44 centimeter mean saphenous vein in length. And for this kind of length, we use mean of 8 cc of foam. So you can be really safe administering this. You mentioned the concentrations, 1% There is one study concerning non-rotational MOCA, 1.5 versus 3%. And the results are like more than 10% less anatomical occlusion if you use 1.5 in contrary to 3%. So it seems that concentration matters. My indications to use MOCA, because honestly speaking, even being the investigator of the MOCA study, I mean, not MOCA, Flebogrif study, I cannot confirm that our occlusion rate was the same as for laser. Laser for me, it's still the first line treatment or thermal ablation, laser radiofrequency. But I see several points and places where mechanochemical ablation can be used, and I'm using this clinically in following situations. First, the patient with axial reflux down to the ankle. So the device, the Flebogrif catheter, is up till 90 centimeters, so you can treat the entire length of the vein using a small amount of foam. Good examples are the patients with venous leg ulcer and axial reflux down to the below the knee segment, because you can perform the puncture in the distal part, you can close entire length of the vein, and then you still have the 6 French sheet around the ulcer, and you can use this sheet to fulfill the sub-ulcer venous plexus, so something which gives you the complete treatment of the venous hypertension also in sub-ulcer area. Patients which have groin neovascularization after ligation and then patent and incompetent saphenous vein, very good model to use this kind of device. You go with the Flebogrif catheter, you inject foam to neovascularization, open the hooks, and you start the ablation below. And then, of course, this what is also the good advantage. This does not need any generator. All comes in the set ready to use. You just need one ampoule of ethoxysclero. So this is the procedure which, let's say, can be very mobile. You can go I mean, you can see the patients having the method ready to use. But there are some places and situations where I would not advise this kind of stuff. So for the large veins, we know that sclerotherapy is not the perfect method for large veins. The Hooke's distance is 27 millimeters, but I'm not using this in the veins over 1 centimeter. Second, veins which are post-thrombotic or after previous treatments with a very thick wall where you will not get the spasm, then you will get the thrombosis. So this is not a good model. And of course, the patients which have extrafascial location of the saphenous vein, then it's not saphenous vein, it's the branch, the tributary. Be careful. You can do this, of course, but you can count on the same complications after sclerotherapy. So you can have the fibrotic cord in the skin, or you can have hyperpigmentations. This is exactly the same as for sclerotherapy, but can be done, of course. And from my experience, longer segment I am treating with Flebogrif, then better results I am getting. I would not use this for 10 centimeter accessory vein, because you usually have some kind of stump in the proximal level. You start this procedure 2 centimeter from the femoral vein, then it's always some risk of recanalization in the proximal segment. So this is a good method which for sure can have the place in your armamentario of the methods, but with some limitations, and there are some situations, clinical situations, when this can be exceptional.
Thank you, Tomasz. I do have a question for you. The question is actually two of them. What percentage of your patients do you treat with thermal first?
I think it's up till 90%.
So you do 90% thermal and then 10% Flebogrif.
Yeah, I mean,
Do you
Flebogrif or
also
glue? I'm using also glue, so glue and the Flebogrif for the 10%.
Okay. And then you mentioned the study of Polidocanol 1.5% versus 3%. Was there any methodology issues that you could cite on that particular paper?
This is the paper I found this in the meantime. This is from Italy, Amolo, the first author. Occlusion rate at 3 months, but the problem was that small groups of the patients, 12 groups in each group of the patients, 1.5 versus 3, so altogether 24. And in the group of the 1.5, there was 2 recanalizations, 0 in the patients with 3%. Regarding recanalization, in our study we had a very few, relatively few, after 1 year, like 5% of the total vein recanalization. After 2 years, around 6% of such cases. But in some cases, we found the partial recanalization in majority of the cases without reflux. But this is something which, for all sclerotherapy cases, can happen, and the patient has to be followed. Of course,
yeah, I'm going to need, Tomasz, I'm going to need to switch to some of the questions that are from the audience. I suspect that all of you use compression post-procedure. Is that correct?
Right, correct.
Yes, like after normal sclerotherapy.
Yes. Then the question is limitations, Imre, for your device being Invira?
We don't know yet
Size?
what
Size?
size may be. This is one limitation, but we don't know exactly what size it is suitable and what size it won't be really suitable. Maybe post-thrombotic cases or very big tortuous veins. So we don't know yet because all the first results were really excellent. So maybe in the future we will see as we are using this device.
So if we look at the non-thermals, non-rotational, or even rotational, there seems to be a limitation in terms of size in comparison to the thermals. So I think we need to be aware of that going forward. I would be remiss if I don't mention Sclerosafe as a non-rotational device. They're trying to get their mechanical approval at this point, but it was presented a week or two ago by myself in terms of what was going on with Sclerosafe, which, by the way, is also approved in the United States, which is a catheter that delivers foam through a double syringe, one that aspirates and one that delivers, with very good results that were published outside of the United States. That being said, how do we select a device? I mean, we all have all these different devices going on, and there are probably more devices that are being developed that are rotational coming forth. Tomasz, I know that you've been married to Flebogrif for a long time. It's been out there. I remember it being presented by the inventors at the AVF, and it was exciting to see. And now it's starting to spread across Europe. I wonder if it's going to come to the US.
From the company, I heard that they are thinking about this, but I cannot tell you any kind of details, so it should be good directly ask them. But I see the papers with Flebogrif coming from Asia, from Europe, from South America, from Mexico. So it seems that this is no more local technology. It's something which is taking is playing the role in a global market right now. Of course, we do not have head-to-head comparison with Clarivane, which would be good. And I think that, of course, as in other techniques, the proper qualification, proper patient selection, and proper procedure performance matters, because we can do whatever, what has to be
So
done.
it's interesting that Attilia Puskas did in the chat group from Romania talked about his results with 60 cases, 92% occlusion at 6 months. Do we really feel that 6 months in a non-thermal is satisfactory to use as a standard, or should we go out with more than 6 months? Javier, what do you think?
If Javier, if you...
Did you hear my question,
The question
Javier?
was to you.
Yes, I didn't hear you. Can you repeat, please?
Sure. We are looking at 6-month follow-up with an excellent result from the Romanians and with Flebogrif, and same thing with Invira. Now, do we think that 6 months is the standard litmus test for non-thermals, or should we go out further? Should we look at 1 year? Should we look at 5 years? Because we know that with a competitive device, Claravane, that they started seeing decay significantly after more than 6 months, after a year, and then up to 5 years. So, Tomas, Javier, what do you think, Javier?
Yes, but to me, 6 months is a very short time because we need more time to evaluate and compare it with another kind of devices. For example, in our case, in the 3 months, we have the similar results. So to the first year, 92%. After 3 years, we can identify the 90%. So for the reason I say, I need to continue the time. I need to have new patients, more time. And after 5 years, I say that I can be very honest, and I want to share the final results. But we are working in the last part of this study.
Tomas.
I think that 6 months is a very short time. We have the observations, the longest to study which are available are 2 years with around 90% of occlusion rate and veins without reflux. We need longer in Clarivane studies. We have right now 5 and 8 years observations. Of course, the results are going down, which is obvious. It's, as I said before, it's not the first line therapy for all the cases, but for some of them it's essential. So in most of the practices which works in phlebology, we usually have one thermal and one non-thermal methods. But if you have
I'm not going into that, Tomas. But we're talking about length of time. And we know that in thermal that at 1 year, 90% of the veins are disappeared. We don't know that with non-thermal because non-thermal, they still do exist. So if they still exist and they're not decreasing in size, there's always a chance for recanalization. But I think, as you said, most of us do thermal and a combination of non-rotational, rotational, or even just foam. That being said, we have 2 minutes left, and what I want to do is thank everybody for being available and having a brilliant discussion. And next week, we are actually shifting to the deep side. It'll be a case discussion of iliofemoral stent placed. But the litmus problem is that the patient has a nitinol allergy, and what to do when a patient has a nitinol allergy and they have a nitinol stent placed. So we look forward to having KJ Nagashev presenting and Stuart Dagansey as a discussant and Michael Lichtenberg. So we look forward to seeing you next week, and thank you to our presenters and discussants, and have a great day.
Thank you. Me too. It's a pleasure. Take care.
Thank you.
Thank you, everybody.
Thank you.